Welcome to another session of critical appraisal as a part of this short course in clinical epidemiology. Today we have Dr. Nivin who will be critically appraising a pragmatic trial. So more and more we are looking to randomized control trials which have more generalizability and external validity. So one such study is a pragmatic study design. So Dr. Nivin will just go through the basics of what is a pragmatic study and also will critically appraise it using a tool, critical appraisal tool called Precis. So without any further delay, I'll hand over to Dr. Nivin and then we'll open for questions and then proceed to the next session on artificial intelligence. So that is how we have planned the sessions for today. Thanks.
Thank you, sir. Good morning, everyone. So I'll be talking about pragmatic trials today. So initial part would be, like sir mentioned, an introduction to what pragmatic trials is, and then subsequently we critique pragmatic trial together. So if you notice, there are some handouts that are given. That would be the precision to checklist that is there. So you guys, as we are going along, as we discuss the trial, you guys can go through it and critically appraise it yourselves. Yeah, so I'd like to start off with this one study that was published in 1967. So this is a review by Schwartz and Vellore. So this talked about two types of trials. So the first type is one that follows an explanatory approach, that is more of based on understanding, based on a theory of significant tests. So that is, if there's an observed effect, is it based on statistics or is it purely by chance or not? Yeah, second type of question is pragmatic approach. So it's aimed at decision. So it seeks to answer the question, which of the two treatments should be preferred? Okay, so unfortunately, most studies nowadays trying to follow the explanatory approach rather than the pragmatic approach. So where are we today? So that is the 1967. So where are we today? So we find that this is a systematic review that was done in 2020. It shows that nearly quarter of the trials exclude 89% of the patients that have the condition, and nearly half exclude 77%. So common conditions like hypertension, at least 83% of the patients are excluded. This is based on 50 trials that they reviewed. Lipid lowering agents in primary prevention is 85%, type 2 diabetes 81%, COPD and asthma also a large proportion. So the conclusion is most patients of that physical condition would be excluded from those trials. So that's kind of unfortunate. Maybe slightly an over-exaggeration, but the underlying statement is that it happens because older people are excluded, those with significant comorbidities and co-prescribing are excluded. So this is a traditional randomized control trial which looks at what the goal is the experimental condition effective? So the intervention should be the only difference between the cases and the control. So this is the ideal setting. Whereas we have pragmatic trials. So this is where the intervention is effective in a real world setting. So like I mentioned earlier, majority of the studies nowadays is explanatory, which forms the base. And there's very few pragmatic trials nowadays. So the advantages of the pragmatic trials is it has a very high external validity. So it's quite generalizable. It's a large sample size. It's probably a simple design that can be incorporated easily into daily practice. Diverse setting, and usually mostly it's phase 4 trials, whereas explanatory is phase 2 and phase 3. So again, another pictorial representation of different types of trials. Here we have your placebo-controlled randomized control trial, which divides into two specific groups. There's a very clear inclusion criteria, clear exclusion criteria, looks at more of efficacy. Okay, so this is whether the intervention will work in the most ideal situation. Whereas we have your pragmatic RCT, which includes all elderly, people with comorbidities, multiple other socioeconomic factors, everything is included, and they look at whether the intervention will be effective in the real world setting. So usually our reviews usually address questions about internal validity, and we kind of sometimes forget to think about external validity, what is relevant to the patient in front of us. So a few points that we can get from pragmatic trials. The first question is, how effective is it in routine patient care? So the pragmatic trial would kind of look at all our normal patients that we see in clinical practice, whereas the eligibility of an explanatory trial is very highly selected patients. Will the intervention be effective regardless of the setting? So here we're looking at, okay, it's delivered by a physician who in routine practice, primary care, secondary care, whereas the intervention and explanatory trial may only be given by probably expert clinician researchers. Then how well is the intervention tolerated in the real world? So is it flexible in adherence? Is it flexible in delivery? Does it need a lot of follow-up? So efficacy of intervention vary over time. Do we need multiple recordings or as usual, as we follow up a patient after 3 months, is the intervention still valid then? So healthcare policy, does it improve costs, reduce costs, sorry, and improve outcomes? So pragmatic trials can actually test policy and drive policy decision. And again, is it effective in routine practice? Again, test implements of the intervention routine care and implementation for explanatory trial. It lacks the information about how the intervention may be implemented in routine practice. So Precise toolkit is one of the ways that we can help design a pragmatic trial. So it's, even though we are using it now for critical appraisal, it's actually used for designing a pragmatic RCT. So it's not a binary. You should know that explanatory and pragmatic trial is not a binary thing. So it's actually a continuum. So there is explanatory trials which have ideal situations and pragmatic trials which are the usual care standard. And it helps the multidisciplinary team make consider the applicability of the research results and create relevant research and prevent wastage of time. So again, this is a continuum. So we have RCT on one side, pragmatic trials. So there may be features of both in either. So you have to kind of decide which is the ideal thing for you. Okay, so this is the Precis 2 wheel that we see. So there are 9 domains. So looking graded from 1 to 5. So 1 being explanatory and 5 being highly pragmatic. If it's 5, it goes all the way top. So it looks at eligibility, recruitment, flexibility in delivery, flexibility in adherence, primary analysis, primary outcome, follow-up, organization, and setting. So these are 9 things that they look at, and this is the things that they want us to consider. So we kind of do the scoring for each domain and end up with a visual picture as our design, and it should be ideally a complete wheel. Okay. And then we decide, okay, are my designs consistent? Are we designing the trial that we wish to design? So the first thing is eligibility. Okay, so how are the patients selected into the trial? Are we using a very strict inclusion criteria, typical patients? How are we recruiting them? So are we going out of our way to recruit them, or are we recruiting them as they come to our clinical practice? Or are we sending websites, invitation? So then we may not get the ideal, we may get people who are highly motivated, but we may not get our usual patients that we see in routine day-to-day practice. So the setting can refer to either this where it's being done geographically or the healthcare setting. Is it in primary care, secondary care, tertiary care? So is it in primary care that all the results can be applied easily, or is it only at a very high specialist center? Then the generalizability comes down. Organization, do we need a lot of infrastructure, additional infrastructure from what is already available? So is it like doing a surgery for a procedure, like it's a tertiary care center, we're doing an extra surgery? It may already be, we may be able to do it already, but whereas if you're looking at something which need additional input, additional training, that may be more explanatory in research. Flexibility, how should the study or the intervention be delivered? So is it flexible? Okay, the practitioner who is delivering the intervention is very flexible. So for example, is it something like a surgery which has multiple steps and each steps have to be clearly followed for the end result? Or is it something like cognitive behavioral therapy where it's kind of flexible, depends on how the practitioner is using it? So next thing is adherence. How do the participants or the patients who are getting the intervention, how do they respond? So are they able to respond as they usually would do in day-to-day practice? Or like, for example, if they're given a drug in a trial setting, if they're given a drug and they find out that the compliance is low, the trialist may suddenly go and give another feedback saying, okay, you're not taking a drug, you have to. So that might be a little deviate from the usual care path. Next thing is follow-up. How closely are they followed? Are they followed up every 1 month, 2 weeks, a lot of data being collected, or is it something that you would routinely collect from your electronic health records and you would call them at 3 months or whenever you would call that patient? Next thing is how relevant is the primary outcome? So do they use a lot of surrogate markers which may not actually be relevant for the patient? Bone mineral density, as for when the patient is actually more worried about, okay, does the patient get a fracture, something like that? And is it outcomes of importance to the patient or the participant? Participant can be the patient, it can be the decision maker or the physician. That's primary analysis. So is it related to, does they include all patients? Is it predominantly intention to treat, or have they excluded a lot of groups and there's a lot of practice variability that is there. So on one hand, we have explanatory clinical trial. So if you plot the diagram for explanatory trial, it will be quite small because everything is very controlled. Whereas an observational study is relied on real world evidence. So it's quite large. However, there's a lot of bias that can creep in. So we get the best of both worlds by doing a pragmatic randomized control trial where we may not get as much the same, but it depends on, I mean, we get kind of the best of both worlds. And we'll see how applicable it will be to real life setting. So there are limitations also. The limitation is, again, we cannot use a pragmatic trial, if, for example, if the indication of the intervention has not been clearly specified, or if it's a large sample size, I mean, there will be a long follow-up period, there will be a huge cost burden also sometimes. Then exact magnitude of the effect also may not be very clear if there's a large amount of non-adherence. And perspective also, for example, if you are a patient who is very compliant to all medical care, will this apply to you? Perhaps not. You may have to, but from the decision maker point of view, it may be quite useful. So it's come to the case scenario. So first is you are the medical superintendent of a tertiary level medical center college, and you're catering to a large community in southern India. So you know that stroke is one of the leading causes of morbidity among ages more than 50. And you want to you're tasked with decreasing the incidence of stroke. One strategy suggested by your team is to improve drug compliance in patients with hypertension, so routine cardiovascular disease. So your team shows you this meta-analysis from 2016, which has been widely publicized. So this is a meta-analysis showing that patients who, if they are given a text message reminder, then they kind of have better compliance. But then you being an astute clinician, you realize that most of the trials are low quality, have very low sample size, and a very short follow-up. So you decide to do a PubMed search and you find this article. So this is published in JAMA, that is last week. So this is personalized patient data and behavioral nudges to improve adherence to chronic cardiovascular medications. So they have clearly mentioned that it's a randomized control trial. So I'll use the CAST checklist to critically appraise this trial. So section A is the basic study design valid. So what is the PICO statement? So the population that they included were patients between 18 years of age and less than 90 years of age with presence of one or more cardiovascular risk conditions as per the ICD. So either hypertension, dyslipidemia, diabetes, coronary artery disease, or atrial fibrillation. They had 3 interventions. So intervention arm was either a generic reminder text message, a behavioral nudge text along with the reminder, and a behavioral nudge plus they were able to access a chatbot. So I'll give examples of this subsequently. The control was the usual care. So usually we would not send text message reminders. The usual standard of care would continue in the control arm. The outcome they looked at was the refill adherence. So how adherent was the patient to following the therapy. So proportion of days covered is what they did over the next 1 year following randomization. So the setting, this was a predominantly tertiary care center. So 3 large centers called UC Health, that's University of Colorado Health, Denver Health, and the Veteran Association Healthcare Systems. Predominantly secondary and tertiary care, not much of primary care. Inclusion criteria has, along with the previous one, they should have had prescribed 1 or more medicines to treat the condition within the prior 100 days. They would have got a letter in their mail, and if they are not opted out of the trial, then they would be included. Plus, they should have had a refill gap of at least 7 days. So this again becomes slightly more specific and a selected trial. So I would assume that this group is definitely the worst offenders, those who did not take the drugs even though they were given 100 days ago. So this would be the worst offenders. If the trial worked in this population, probably it would work in the real life setting. But again, it may not be generalizable to a patient who is more compliant. So the exclusion criteria, again, those who didn't have a landline or cell phone listed reasonable, those who are enrolled in hospice or palliative care. Okay, then next was home address outside Colorado. The 4th and 5th was those who are non-English speaking or non-Spanish speaking. And so I looked at this Migration Policy Institute. So this showed that those who speak English is, I mean, less than very well, though maybe have difficulty with English is close to 54,000. So they would have, if you look at the whole thing, those who, if you exclude those who didn't have no English or Spanish, you kind of skip around 69,000, which is kind of a large amount. So if you were doing this in India, then probably you would have to include multiple languages as well. Current pregnancy, I'm not sure why you would be excluded because there doesn't seem to be any biological explanation why you want to exclude pregnant women. They are just getting a message telling them to take the medicine. So I would include them in the study, in this study if I was doing it. So the outcomes that they looked at, primary outcome, refill adherence. So look at the proportion of days per after the 1 year following randomization. Secondary outcomes, they looked at median gap lengths from the first initial refill. Then they looked at subsequent gap lengths and then time to clinical outcomes. So that ED visit, hospitalization, mortality, and they censored from right censoring from death or end of follow-up. So was the assignment of participants to interventions randomized? So randomization was stratified by healthcare system and number of baseline medications that were there. So they stratified them and then also blocks of 4 within each strata. So was the assignment of participants to interventions randomized? So this is the only line I could find out about randomization, saying that it's using an automated process. So probably they used a computer generated, and however, they have not really mentioned about allocation concealment. These are things that they could have easily specified. So were all the participants who entered the study accounted for its conclusion? So was everyone accounted for? So here we notice that 13,000 individuals were sent out the letter. 3,943 were excluded. So majority of them did not have a refill gap. 1,300 kind of opted out, and 415 were the mails were not delivered. And subsequently, come 9,501 who were randomized into 2,300 arm who received the generic message, 2,300 who received behavioral text, and the other one had the chatbot and usual care. Surprisingly, they have done a modified analysis. There is around some amount of dropout that is there. So 2.2, 2.8, 2.3, and 2.3% were dropped out from each arm, and they didn't kind of include the whole thing. So I would have assumed that if being a pragmatic trial, they would have done intention to treat analysis, but they have actually done a per protocol analysis, which is something that was glaring. Loss to follow-up 2.2% maybe. I mean, there were some that opted out, which can be explained. Even loss to follow-up in such a large study, 47 out of 2,000, seems like a reasonable number. So how did they go about the messages? So they use this upland communication messages. So either they send messages in English or Spanish based on what the preference of the patient was. They delivered only when the patients had a refill gap of 7 days. And then they would send subsequent messages on day 1, day 2, like that. And patients without cell phones, they would do an automated voice call that was there. And messages were stopped once the pharmacy record showed that the medication has been, the prescription had been filled, or the patient replied saying it was done. So the study was deemed as minimal risk, so they kind of waived off the consent and they'd obtained IRB approval from the Colorado IRB board. So this is an example of a text message that they were sent. So generic reminders on day 1, you didn't fill the prescription for 7 days, you get the day 1 reminder, you are due for this drug name. And if you have already filled, you will write done. So this behavioral thing is more of, they say that, I mean, based on the concept that people make decisions either intuitively or they make based on rational. So intuitively is based on emotions, your past experience. So this is kind of like how we have noticed that you have not filled your prescription. You can either say you refill them in 2 days or you're still working on a plan. So it's kind of nudging you to kind of get the prescription. And the chatbot is, again, there's a set of questions that were answered. So if the patient has any doubts about the medication, they can send it to that chatbot. Similarly, so this would be done on day 1, 3, 5, 7, 10. So 10 multiple days following the time they did not take the medicines. Okay, so what was the methodology sound? So participants were not blinded, so they were clearly knowing what group they were in. Intervention, investigators and outcome assessors also, it's not mentioned, but again, they were looking at objective outcomes. So they're looking at the days or proportion of days. So it seems more objective. However, if you're looking at hospitalization, that is something that could have been influenced by the treating physician. So again, it could modify physician behavior to some extent. If the physician knew that, okay, I was in the arm that was receiving the chatbot and behavior tests, I may not spend that much time with the patient explaining compliance. So there may be some difference there. So were the study groups similar at the start of the randomized trial? So looking at the baseline characteristics, majority of the characteristics seems to match. It's definitely not similar to our population. So there's Asian is only around 1%, marriage is around 43%, and the number of patients who have insurance cover is only 9%, whereas ours would probably be much more. Then veteran association, again, there was 13%. So veterans, we know that is not like the general population. They're more of probably, they would be more disciplined, I would guess, or more, more disciplined, and this intervention may not work in them. That's another thing. So it's a little different from our population. Other thing is looking at the number of qualifying conditions. So they have around 60% who have more than one qualifying condition. They included patients who had substance abuse, depression, those who had multiple active classes or groups. And majority, as you can see, required the text message, and only 9% required the interactive voice response. Probably in ours, it would be slightly higher. So the things that we are looking for is, okay, polypharmacy. They have mentioned how many patients, multiple classes that the patients are on. Probably something that they could have mentioned is cost. Again, cost, if it's covered by insurance, it's not really counted for us. Then literacy was something they could have mentioned. Coexisting psychiatric illness, they have mentioned. So again, all these things seem to be randomized well. So we are all the confounding factors. The known confounder seems to be equal in all forums. So we assume that the unknown confounder is also matched equally. So was there any co-intervention? So like I said, in that patients could, so there is one facility where patients could return a text message and they could be responded to by a clinical pharmacist. So this could actually lead to probably more close observation. Maybe the pharmacist would have said, okay, you need to meet your doctor. That could have led to co-intervention. And again, how frequent were they followed up? So they were followed up quite, the patients, how often they were followed up clinically or they came to the hospital is not mentioned. But the data was collected every 1 month. And how long the initial prescription for all those details are not mentioned. So how did they calculate? How did they do a power calculation? So they assumed that they would detect a 10-point difference in the adherence between those in the usual arm versus those in the intervention arm. And they said with 80% power, they would have to calculate around 476 patients. But they have calculated, of course, they have gone above that. They have enrolled 9,500 people, thinking that they have mentioned multiple reasons. So they wanted to know if they should have had enough power to rule out a type 2 error. Plus, it was related to it was funded by a pragmatic study group. So they wanted to include as many people as possible. Objective outcomes. So there is some, they did look at objective outcomes. However, there was some ambiguity. So, for example, if the patient had filled the prescription elsewhere but failed to reply that he had done that, or there was some delay, then probably there would be some objectivity in measurement of the outcome. So they calculated the PDC based on the pharmacy records, whatever records they had each month for 12 months following randomization. So again, results were expressed as mean difference. The missing data they had considered to be missing at random, and they had put special weights, and they had done used an imputation method to kind of fill those details. So potential source of bias, again, performance bias, perhaps due to co-intervention, maybe not very significant. Measurement bias also, if the patient failed to reply appropriately at the correct time, especially in the usual care arm. How do we know what is the if the patient did not reply in the usual care arm, we'll have to kind of rely on the pharmacy records, so that can be slightly difficult. So statistical records, they use this generalized estimating equation in R, and they had kind of looked into, that was put into a regression model, and that had that accounted for kind of repeated measurements from the same subjects longitudinally. So looking at the validity of the study, it seems to have worked. The study population was clearly well defined. Outcomes or objective randomization, they have mentioned clearly it was automated and computer generated. Allocation concealment, they were not very clear with. They implied that it was done. Blinding, again, not done. Sample size appears to be adequate. Intention to treat analysis, unfortunately, was not done. And baseline characteristic was matched, probably, but not similar to our population. So the internal validity, how they could have been a little more better. They could report clearly allocation concealment. External validity, okay, it is definitely more generalizable, considering they used the opt-out strategy for recruiting patients, and they included a wide variety of patients. So looking at the results, so here we see that differences, here the unadjusted proportion of days covered. So they have mentioned for 3 months and for 12 months. At 12 months, for the usual care arm, it was around 60%, whereas for the generic text message 62, 62.3 and 63. So the difference that they wanted was 10%. They had not really reached that difference of 10%. So the difference they had was only 2.2%. And the confidence interval is clearly crossing 1, whereas even behavioral nudge is 2, and behavioral nudge plus chatbot also was 2.3. So they did not reach the difference that they were hoping for, and it doesn't seem to be, I mean, it seems to be crossing 1 also, indicates that it may be equal actually in both terms.
P-value is significant.
Yes, the p-value is significant, but they had mentioned that the p-value should be 0.05 by 3 to be significant. Yes, sir. So they had mentioned that. So again, looking, they had kind of made Kaplan-Meier curves also. So initially, in the initial 3 months, it seems to have some novelty and it seems to work a little bit, but then subsequently kind of becomes equal. Even if you look at the adjusted difference of usual care, looking at death, hospitalization, and emergency visits, again, there were not many deaths, but then it looks like more or less the same in all 3 arms. So it didn't really make much of a difference, the intervention. So how precise was the result? So again, yes, confidence intervals have been reported kind of clearly crossing 1, quite wide confidence interval. There was a sensitive analysis was done, but that was done after removing those who had not received, never taken the medicine, those with long gaps. However, they have not done a worst case scenario for those who had missing data. So they had mentioned that for one of the centers, they had 7, the maximum follow-up was at least 7 months. So they have not really done a worst case scenario for those patients. So, do the benefits of the experimental intervention outweigh the harms of the cost? So, there's no harms other than probably mild annoyance if you're getting multiple phone calls, and that might be the only thing. No cost-effective analysis is done clearly, something that could have been addressed. And can the results be applied to your local population? So, it's not clearly similar to our population. It's not a similar demographic. Literacy rate may be definitely different. Probably our patients may not be reading their messages. Probably they need automated voice response. Socioeconomic status is something that they need to consider. Outcomes may clearly be different. Our patients probably may respond better if they felt that the doctor was messaging them. That would be something, or they had back and forth feedback, bi-directional talk they could do. Definitely relevant outcomes. So patient compliance is indirectly would result in less incidence of other diseases. Things that probably a physician may be interested in glycemic control. Even patients would be saying, okay, my BP is not controlled, so they would want to look at BP control. Cost is again quite important. So experimental interventions provide greater value. So probably definitely there would be, if we had to do it in our setting, there would be initial investment, and then probably we can automate it, link it to a pharmacy records. But again, maybe definitely there will be challenges doing that. Cost would be an issue, but in the long term, the benefit may be good if it showed benefit. And definitely one thing that we can do is incorporate AI, which would definitely make things much easier. And if we had interactive messages from an AI chatbot saying, okay, do this, do that, would be definitely continue to be novel. That's something. So coming to a Precis 2 trial, this is critically appraising the trial, how it did overall, how pragmatic it would be. So I put score of, I mean, all of you can also score if you like to score. So eligibility wise, I felt they gave a score of 4 because they had included anyone who had a landline, those who understood the language, but then they skipped some people who didn't take the medicines for up to 7 days. So it's reduced by 1 point, but they did include a lot of patients with psychiatric illness, multiple comorbidities, so definitely 4. Recruitment, even though they had sent a letter out, which is slightly difficult, you sending a letter out, they used an opt-out strategy. So that because the patients may not want to opt out, so they would have included a large variety of patients. So it gave a score of 5. So the setting in which it was used, so it's identical to the setting in which the results would be applied. So only thing maybe primary care was kind of left out. So probably they could have included that as well. So gave a score of 4 because this interventions, especially in a resource poor setting, may be more useful. If you knew how to message patients, improve compliance, that would be something that would be valuable. Sorry. Yeah. So then coming to the next, which is organization. So we can do it using a messaging system. We just need that, but probably some additional training may be needed. Probably even we would have to link the messaging system to the pharmacy records. That's something that could need some additional infrastructure. How flexible could we be with the delivery? So this I've given 5. I mean, you can deliver it however you want. How do you want the text message to be sent? The physician could alter it as much as they want to. And okay, you can add the AI chatbot or delivery of drugs, all those things can be done. So even adherence, so even the patient getting the message, they could also adhere, however, they could interact with the intervention as well as they please. So highly pragmatic, so again, scope of 5 by 5 in both. Follow up, they followed up, I mean, it's not mentioned how often they followed up clinically, but then the data was collected every monthly. So probably that's not something that we could do, maybe slightly more explanatory than pragmatic. So I would say I give it a score of 3. Primary outcome, again, definitely, even though it's a surrogate marker, it's definitely an important surrogate marker. So I'd given a score of 5. Primary analysis, since it was a protocol analysis, I've given it a score of 1. I would have expected them to include that, especially since there's a lot of missing data and they've included all that. They should have done an intention to treat analysis. So back to our scenario, based on the results of this study, would not use text message on users on the phone to improve compliance among patients. However, I would like to go and find out more Indian data, perform another study where we would kind of incorporate it into our usual practice without a lot of infrastructure. So you could include primary care, mission hospitals. You could send reminder messages regardless of whether there is pharmacy records. So we don't technically have to link it with pharmacy records, and do an intention to treat analysis and probably even link it to delivery of medicines if the patient wants. So these are some of the resources. One is rethinking clinical trials. It's like a course on pragmatic trials. It's quite useful and free of cost. The other one is the Precis 2 checklist, which again has more resources on that. So the takeaway points, it depends on what is your research question. So you kind of look at what is your research question. Are you looking for, is the intervention going to work in the ideal scenario or is it going to work in the real world scenario? Then should you use a pragmatic study design? If so, then you can use this Precis toolkit to design a trial. In the end, it's always a fine balance. So it's a balance between relevancy and efficacy. You have to kind of balance both of the arms. And there are some trials, of course, which will have some elements that are pragmatic, explanatory. And this pragmatic trials will kind of show you which are the barriers to implementing these resources in the real world setting. Thank you.